All right, good evening. We're going to get started. We've got a pretty long chapter tonight, so we're going to try to get this going, and we will move forward tonight. Your module test will also open up tonight, so you'll have until Monday to complete that. Remember, your module test is given 4 days. Chapter test is given 3 days. All right, so we're talking about special populations tonight, so we go over OB. Applies the fundamental knowledge of growth, development, and aging and assessment findings to provide basic emergency care and transport for a patient with special needs. Talk about OB, recognize and management of a normal delivery. Let's talk about vaginal bleeding in the pregnant patient, anatomy and physiology of a normal pregnancy, and pathophysiology of complications during pregnancy. Assessment of the pregnant patient, what do we need to know? We'll talk about management of normal deliveries, abnormal deliveries. We'll talk about a nuchal cord, prolapse cord, a breech delivery. So there'll be some pictures in here. It's just part of life of delivery of child, so I'll be prepared for that. So we'll talk about managing these. We talk about third trimester bleeding, talk about a placenta previa, abruptoplacenta, spontaneous abortion, miscarriages, ectopic pregnancies, preeclampsia, and eclampsia. All those will be broken out into the pregnancy world. They all can affect us, and we'll see a lot of those through our career as we deal with pregnancies. Neonatal care, assessment and management of a newborn. We also have to take care of them. So sometimes we may be dealing with one patient, have a delivery. Now we have 2 patients we have to deal with. We'll go depth a little bit into neonatal resuscitation. Should also base that off some of your CPR. So that information should be kind of a refresher. So we talked about traumas. We know in every single other slide out there, trauma applies to the fundamental knowledge to provide basic emergency care and transportation based on assessment findings for acutely injured patient. Now, let's dive off to the meat and potatoes. So in special considerations in trauma, we want to recognize what a patient management of a trauma patient for pediatrics, pregnancies, and geriatrics. We'll talk about patho assessment management in the trauma patient of the same pregnant, pediatric, geriatric, and cognitively impaired patient. I'm like a tongue twister there. Whew. Most childbirths in the U.S. Occur in healthcare settings. That's most of them. Sometimes we get to do those in the field. Occasionally, the pregnant woman is unable to get to the hospital. So we must have figured if we're going to transport or we're going to deliver on scene. We're going to assist the deliveries and then transport the patients to the medical facility. So and the ovaries are 2 glands, 1 on each side of the uterus. We've shown y'all pictures before into that. But each ovary contains thousands of follicles, and each follicle contains an egg. Ovulation occurs approximately 2 weeks prior to menstruation. If fertilized, the egg implants into the endometrium of the lining, the inside of the uterus. If the egg is not fertilized within 36 to 48 hours, after it has been released, it will die and then the lining shed as menstrual flows. It occurs around the 28th day of the women's cycle. The fallopian tubes extend out laterally from the uterus with 1 tube associated with each ovary. Whew. Fertilization usually occurs when the egg is inside the fallopian tube. The fertilized egg then continues to the uterus where if implantation occurs, it develops into an embryo and then the fetus and grows until the time of delivery. The uterus is a muscular organ that encloses and protects the fetus. The uterus produces contractions during labor and ultimately helps push the fetus through the birth canal. So I would remember that. The uterus produces contractions during labor and ultimately helps push the fetus through the birth canal. The birth canal is made up of the vagina and the lower third of the uterus called the cervix. The figure on the side shows the anatomic structures of a pregnant woman. We've seen those before without the fetus in there. And then now we talk about the child being in place inside the stomach. So you see the fundus is the very top. You have your placenta, your uterus, your amniotic fluid that surrounds the child through there, your urinary bladder, your pubic symphysis, cervix, sacrum, rectum, and vagina. All right, the vagina is the outermost cavity of the female reproductive system and forms the lower part of the birth canal. This completes the passageway for the uterus to the outside world of the newborn. The perineum is an area between the vagina and the anus. So here, it's going to be in here, right? That area right there. So in a pregnant woman, the breasts produce milk that is carried through small ducts to the nipple to provide nourishment to the newborn once it is born. The placenta is a disc-shaped structure that is attached to the uterine wall that provides nourishment to the fetus. So this keeps the circulation of the woman and fetus separated, but allows substances to pass between them. Anything ingested by a pregnant woman has the potential to affect the fetus. The umbilical cord connects the woman and the fetus through the placenta. The umbilical vein carries oxygenated blood from the placenta to the heart of the fetus. The umbilical arteries carry deoxygenated blood from the heart to the fetus. So that's the reason why when ladies are pregnant and they talk about you have to be careful what you take, certain medicines can pass through. This is what they're referring to, because anything that the female ingests, drinks, eats, potentially can affect the child. It's the same thing with alcohol, tobacco, and drug use. Ultimately, they are all going to make it down to the fetus level and affect the fetus in some form. It could be where you have the fetus is addicted to, let's say, alcohol, drugs, and can come out and also have the tobacco addiction. The umbilical cord is the lifeline of the fetus, and it does connect the woman and the fetus through the placenta. We said that a second ago. The umbilical veins carries oxygenated blood from the placenta to the heart of the fetus. The umbilical arteries carry deoxygenated blood from the heart to the fetus. Those would probably be important to know which vein carries and which the arteries carry. I'll let that sit there for just a second so y'all can write that down. The fetus develops inside a fluid-filled bag-like membrane called the amniotic sac. The sac contains anywhere between 500 milliliters to 1,000 milliliters of amniotic fluid. This does help insulate and protect the floating fetus. The amniotic fluid is released in a gush when the sac ruptures, usually at the beginning of labor. That's what the ladies say when their water is broken. That is technically amniotic fluid. Normal changes in pregnancy. So during normal pregnancies, we have 4 body systems undergo major changes. Those major changes are the respiratory system, the cardiovascular, and the muscular system. Whew, that word already got me there. In the reproductive system, hormone levels increase to support the fetal development and prepare the body for childbirth. This puts the female woman in an increased risk for complications from trauma, bleeding, and some medical conditions. The uterus is displaced outside of its normal, well-protected position within the pelvic area. This increases the chance of a direct fetal injury and trauma, because you remember there's really nothing structural-wise that's surrounding the child. It is just skin, stomach, and sac. That's really all that is protecting the child at these points once they get moved. Rapid uterine growth occurs during the second trimester. As the uterus grows, it pushes up on the diaphragm, displacing it from its normal position. This does create some respiratory compromise. It does increase the respiratory rate, and it decreases their minute volume because there's not enough room for the female to take super deep breaths. It's out of place. So they have to figure out how to adjust their breathing pattern. A lot of times you will see the ladies in a discomfort position. They'll lean over, they'll walk in different forms. It's just their breathing is compromised, so they get shorter breath pretty fast. So overall blood volume does gradually increase throughout pregnancy, although for adequate perfusion of the uterus, prepare for blood loss that occurs during childbirth. So we know that they're going to lose some. The blood volume may eventually increase as much as 50% by the end of pregnancy. The number of red blood cells also increase. The speed of clotting increases to protect against excessive bleeding during pregnancy or during delivery, sorry. By the end of the pregnancy, the pregnant patient's heart rate increases up to 20% to accommodate the increase of blood volume. The cardiac output is significantly increased also. Pregnant women are at the increased risk for gastro reflux, nausea, vomiting, and the potential aspiration because of changes that occur in the gastrointestinal tract. Weight gain during pregnancy is normal. I know a lot of people don't believe that, but it is normal. They're carrying another human. The increase in body weight will eventually challenge the heart and impact the musculoskeletal system. Certain hormones affect the musculoskeletal system by making the joints looser or less stable. In the third trimester, changes in the body center of gravity increase the risk of slips and falls. Post-pregnant women are healthy, but some may be ill when they conceive or become ill during pregnancy. You may safely use oxygen to treat the heart or lung disease in a pregnant patient without harming the fetus. And diabetes develops during the second half of the pregnancy in many women who have not had diabetes previously. Gastrointestinal diabetes resolves in most women. Gestational diabetes, I'm thinking something else. Gestational diabetes does resolve in most of the women after delivery. The treatment is the same as for any other patient with diabetes. Hypertension disorder. So we know that the blood pressure is going to go up because of the workload. Their heart is not changing size, it's just the workload is increasing. So gestational hypertension is the presence of high blood pressure in the absence of other systemic effects. This is defined as a systolic blood pressure higher than 140 millimeters of mercury and a diastolic blood pressure higher than 90 millimeters of mercury. Considered severe when the systolic blood pressure is higher than 160 and or the diastolic has a higher pressure of 110 millimeters of mercury. Preeclampsia, or pregnancy included hypertension, can develop after 20 weeks of gestation. This is characterized by the following signs and symptoms. So we have severe hypertension, severe or present headache, visual abnormalities such as seeing spots, blurred vision, or sensitivity to light, swelling in the hands and feet, which is edema, dyspnea, and or retroperitoneal chest pain, anxiety, and altered mental status. Eclampsia is characterized by seizures that occur as the result of hypertension. To treat these seizures, the only thing that we can do is lay the patient on their side, maintain the airway, administer supplemental oxygen. If they start to vomit, we suction it. provide rapid transport, and call for ALS to intercept. Medicine is restricted. Transporting the patient on her left side can also prevent supine hypotensive syndrome caused by compression of the descending aorta and the inferior vena cava by the pregnant uterus when the patient lies supine. So we say we put everybody in the left lateral recumbent position, but remember, for the pregnant females, this may actually become a little bit more severe than what we are used to doing, because not many of us deal with a lot of pregnant people. We don't deal with a lot of pediatrics either. We morally deal with non-pregnancies and no pediatrics. It's rare unless you're on a pediatric specialty truck that comes out of the hospital. So bleeding is an internal, there may be signs of an ectopic pregnancy. When the embryo develops outside the uterus, most often in the fallopian tubes. Sudden onset of severe abdominal pain and vaginal bleeding in the first trimester or first trimester of pregnancy. This should be considered an ectopic pregnancy until proven otherwise. Consider the possibility of an ectopic pregnancy in a woman who has missed several menstrual cycles and complain of sudden, severe, unusual, unilateral pain in the lower abdomen. Sudden onset of severe abdominal pain and vaginal bleeding in the first trimester of pregnancy should be considered an ectopic pregnancy until we can be proven otherwise by the hospital or other medical facility. Consider the possibility of an ectopic pregnancy in any woman who has missed a menstrual cycle and complains of sudden, severe, unusual, unilateral pain in the lower abdomen. So hemorrhage from the vagina that occurs before labor begins may be serious. In early pregnancies, it may be a sign of a spontaneous abortion or a miscarriage. In later stages of pregnancy, it may indicate that a ruptoplacenta is where the placenta separates prematurely from the wall of the uterus. It is most commonly caused by hypertension or trauma. The placenta previa develops over and covers the cervix. Any bleeding from the vagina in a pregnant woman is a serious sign and should be treated promptly in the hospital setting. We are going to treat these patients like we're treating them for shock, place a sterile pad or sanitary pad over the vagina, and replace if necessary. Remember, we do not pack the vagina. So the two figures show abruptoplacenta and a placenta previa. Here is your abruptoplacenta right here. See how it's broken loose and they're starting to hemorrhage. And you see here the placenta previa, and it develops and covers the cervix. So this is not where it's supposed to be. It is detached and just rotated around. Still going to have blood bleeding around. We are not going to be able to figure that out in the field, but we do a good enough assessment, we're going to be able to pass that information on. So once they do a quick scan, they're going to know if we have an abrupto or placenta previa. So, and an abortion. So we don't just think abortion about where you go to the clinic and you have the baby removed. A textbook, abortion is a spontaneous abortion in the loss of pregnancy prior to 20 weeks of gestation without any preceding surgical or medical interventions. The term is often used interchangeably with miscarriages, and in an induced abortion is the elective termination of a pregnancy prior to the time of viability. The most serious complications are bleeding and infection from an abortion. If the woman is in shock, treat and transport her promptly to the hospital. If the woman is in shock, sorry, I read that one. I should cross them out as I read them. Bring any tissue that passes through the vagina to the hospital, and never, ever, ever pull tissue from the vagina. If for some reason you have to look and you see tissue, leave it there. If we go to put pads over them and we replace the pads and you see tissue, make sure that stays with you and you take it into the facility. An abuse, pregnant women have an increased chance of being the victims of domestic violence and abuse. Abuse during pregnancy increases the chance of a spontaneous abortion, premature delivery, and low birth weights. The woman is at risk of bleeding from an infection and a ureter rupture. Pay attention to the environment for any signs of abuse. Pregnant patients who are abused are often scared and may not be honest as to how their injuries have occurred. Talk to the patient in private, away from their potential abuser, for the information to come out. Substance abuse is also an issue. It affects the addiction of the fetus inside. We may have a prematurely low birth weight, severe respiratory distress. The child could be deceased. Fetal alcohol syndrome describes the condition of an infant born to women who have abused alcohol. We can know that those children come out alcoholics, and they have to be weaned off of that too. It's the same thing with a drug addiction from a child. They're used to having that particular drug, and those babies have to be weaned off of that. If you are called to handle the delivery of an addicted woman, pay special attention to your own safety. Clues that you are dealing with an addicted patient may include the following: the presence of drug paraphernalia in the area, empty wine or liquor bottles around, statements made by the family or bystanders about the patient herself. If the newborn will probably need immediate resuscitation, be prepared. Always have your pediatric equipment out. Don't just bring your ALS delivery kit in. You always want to make sure you have your pediatric stuff on standby also. So some special considerations for trauma and pregnancies. With a trauma call involving a pregnant woman, you have two patients to consider: the woman and the unborn fetus. Pregnant women also have an increased risk of falling compared with non-pregnant women. Hormonal changes loosen the joints in the musculoskeletal system. The increased weight of the uterus and displacement of the abdominal organs can affect the woman's balance, which can cause them to have more issues because their belly is pulling them in a direction versus what they're used to. Pregnant women have an increased amount of overall total blood volume and an approximate 20% increase in their heart rate by the third trimester. A pregnant trauma patient may experience a significant amount of blood loss before you detect signs of shock, because remember, their blood volume has increased. The fetus may also be in trouble well before signs of shock are pregnant. Be alert to additional concerns and be ready to assess and manage unique types of injuries when responding to a pregnant trauma patient. If you know that, you can prepare. If you don't, you get there and you're like, oh God, okay, let's make this work. So the uterus is especially vulnerable to penetrating trauma and blunt injuries because obviously there's no protection. A trauma injury to the pregnant uterus can be life-threatening to the woman and fetus because of the uterus has a rich blood supply. In most cases, the only chance to save the fetus is an adequately resuscitate the woman. When a pregnant woman is involved in a motor vehicle crash, similar violent mechanism of injury, severe hemorrhaging may result from the result of the pregnant uterus, or result to the pregnant uterus. Trauma is one of the leading causes of an abrupto placenta. You should suspect abrupto placenta when the MOI is blunt trauma to the abdomen, and the patient's signs and symptoms suggest of shock. Common symptoms include vaginal bleeding and severe abdominal pain. If any female, a pregnant female, is involved in a motor vehicle collision and they complain of any pain, you need to make sure you take them to a facility. You do your best to suggest that you allow them to take you to the facility, because not only could they lose the child, they could also lose their own life. Improper positioning of the seatbelt can result in injury to a pregnant woman and the fetus if they are involved in a motor vehicle crash. Carefully assess the pregnant woman's abdomen and chest for seatbelt marks, bruising, and obvious trauma. There's a lot of times where the placement of the lap belt is not in the right place. They have issues with that, so that's where the injuries come from. If a pregnant trauma patient goes into cardiac arrest, your focus is the same as with other patients in cardiac arrest. You're going to perform CPR and provide transport to the hospital according to your local protocols. If a woman is in the last month or two of pregnancy, compression may be applied a little higher on the sternum than usual. Assessment and management, your focus on the assessment and the management of the woman. Suspect shocks-based MOI. As you see on yours, be prepared for vomiting and aspirations. Anticipate the need to manage the airway and protect the patient from aspirating. Be ready to suction. Attempt to determine the gestational age to assist you with determining the size of the fetus and the position of the fetus. Let's see here. So we're going to maintain an airway. You're going to be prepared for and anticipate vomiting. Administer high flow O2. Ensure that there is adequate ventilation. If the patient's ventilations are inadequate, provide or assist ventilation with a bag valve mask and 100% of oxygen. Assess your circulation. We're going to control external bleeding if there is any, and maintain a high index of suspicion for internal bleeding based on our MOI. And our transport, we're going to transport the patient on her left side, call for ALS, transport to a specialty OB or trauma center if one is available. Some of your trauma centers will deliver children also. Some of them do not have a OB side. They may just take them if it is a traumatic situation. So you just need to know what's in your area and what is the most appropriate facility to transport that patient to. Cultural sensitivity is huge. Be very smart about the cultural sensitivity that's in your area. It is important when you are assessing and treating a pregnant patient. Women of some cultures may have a value system that would affect the choice of how they are cared for themselves during pregnancy, how they have planned for the childbirth process. Some cultures may not permit a male healthcare provider, especially in a pre-hospital setting, to assess or examine of the female patient. Respect all these differences and honor the request. Sorry, my air conditioner went out at my house and I'm having to deal with that 5 hours away from there. Always respect the differences and honor the requests from each patient. Again, if you get there and you're a double mail truck and you realize that it is a cultural thing, please call for a female provider to show up and advise them why you need assistance. It's okay for that. In teen pregnancies, the U.S. has one of the highest teen pregnancies in the world. Pregnant teenagers may not know that they are pregnant or may be in denial about it. As you begin to assess all female teenagers, remember the possibility of pregnancy. Respect the teenager's privacy and need for independence. Childbirth is seldom an unexpected event, but there are occasions when childbirth becomes an emergency. Consider standard precautions. Make sure you wear your gloves, eyes, and mask. Gloves, gown, mask, and eye protection here. Consider calling for a special, if you have a particular system that has a OB truck, I've seen some in the bigger cities, that is a specialty resource. If you need additional resources, be prepared and call for that early. You will encounter pregnant patients who are not in labor, so it is important to determine what the MOI is, nor the NOI. Do not develop tunnel vision during this call. For a general impression, whether the patient is in active labor or whether you have time to assess for immediate delivery and address the possible life threats. Perform a rapid examination of the patient and figure out if this is a stay and play or load and go. Do we need to prepare to deliver this child, or do we have time to transport them to the facility? And remember, it is against the law to transport a lady in active labor. If you're going to be delivering a child, you must pull over, deliver that child. Once that child is delivered, you can then continue on to the facility. During an uncomplicated birth, life-threatening conditions involve the woman's airway and breathing are not usually an issue. However, motor vehicle crashes and assaults or any number of medical conditions may cause a life threat to exist and may result in a complicated delivery. If you need to provide an airway management and high flow O2, do it. Don't wait around. Let's make sure that we get this and take care of it as we go forward. Blood loss after delivery is expected, so be prepared. Most of the time it is not significant, and it's just something that you're going to have to clean the truck up afterwards. Quickly assess for any potential life-threatening bleeds and begin treatment immediately. If signs of shock are present, control the bleeding, give oxygen, and keep the patient warm. If the delivery is imminent, you must prepare to do that on scene. The ideal place to deliver is in the security of your ambulance or the privacy of the woman's home. There should be warm and private with plenty of room to move around. If the delivery is not imminent, prepare the patient for transport and perform the remainder of the assessment en route to the emergency department. Women in the second or third trimester of pregnancy should be transported lying on their left side when available. I have shut down a major highway to deliver a child. I've shut down a major intersection due to a motor vehicle collision that turned into a delivery. I've delivered 13 babies in my career. Some of them, majority of them made it. Some of them were super premature. And I've loved every minute of it. Delivery it's something that is different. I think it's a beautiful process because that is a human bringing in another human into this world. It is sometimes stressful, but is a very awesome situation. Provide rapid transport when a pregnant patients who have signs of significant bleeding and pain. Obviously, there's going to be a lot of pain. I don't know what y'all think, but there's going to be a lot of pain. They are hypertensive. If they're having an active seizure or have altered mental status, these are rapid transports for pregnant patients. All right, so when we start talking about their history, you need to be very thorough, include her expected due date. Has there been any complications that she's aware of? Is there been any receiving prenatal care? And a complete medical history. Some of the questions related to specifically to prenatal care is identify and any complications to the patient that may have had during pregnancy or potential complications during delivery. Determine the due date, fetus movement, frequency of contractions, and a history of previous pregnancies and deliveries and their complications. Determine whether there is a possibility of multiples and whether the woman has taken any drugs or medications recently. If the water has broken, ask whether the fluid was green. Green fluid does mean meconium, which is fetal stool. The presence of meconium, I can't pronounce that now. Meconium can indicate newborn distress, and it is possible for the fetus to aspirate on its own meconium during delivery. If the patient is in active labor, the physical examination should be focused on contractions and possibility of delivery. If at any point you suspect that delivery is imminent, you should check for crowning. If you do not suspect an intimate delivery and the patient reports other problems unrelated to delivery, you should not visually inspect the vagina, the vaginal area. If the female states that they feel pressure, you're going to have to explain to them, ma'am, I'm going to have to look down there to make sure. I had one lady told me she felt pressure. And when I finally got her convinced that I had to look, it's not like I wanted to, there was a baby coming out. So that was the pressure she felt. Obtain a complete set of vitals and a pulse ox. Be especially alert for tachycardia or hypo or hypertension. Hypertension can even be mild and may indicate more serious problems. Repeat the primary assessment with a focus on the patient's ABCs and vaginal bleeding, particularly after delivery. Obtain another set of vital signs and compare with those obtained earlier. Recheck interventions and treatments to see whether they are effective or not. Here again, we're going to, if the delivery is intimate, notify staff at the receiving hospital, provide an update on the status of the woman and the newborn after delivery. So you may be going to labor and delivery initially, but on the way to the facility, you have to stop and deliver a baby. So now you're going to go to OB, labor and deliveries initially. Now you're going to go to OB receiving. It's in probably the same area, but now it's a complete different set of rules and guidelines because the baby is present now. For a pregnant patient with a complaint unrelated to childbirth, be sure to include the pregnancy status of the patient in the radio. If your delivery occurred in the field, you will have 2 patient care reports to complete. Stages of labor. There are 3 stages of labor. We talk about the dilation of the cervix, delivery of the fetus, and delivery of the placenta. The first stage begins with the onset of contractions and ends with the cervix as being fully dilated. The first stage is usually the longest stage and lasting an average of 16 hours. The onset of labor starts with contractions of the uterus. Other signs of the beginning of labor are the bloody show and the rupture of the amniotic sac. Again, that's where the water breaks. The frequency and intensity of contractions and true labor increases with time. Hey guys, let's take 10 minutes real quick. I had somebody come by the clinic, if y'all don't mind. So let's just pause right here and I'll see you at 6:48, 6:50, right around that time. Sorry. Guys, sorry about that. Apologize, I couldn't prevent somebody coming by. All right, let's change here. All right, so labor is generally longer in a prima gravida than in a multigravida. A woman may experience premature or false labor, or what we call Braxton Hicks. I looked at this earlier, and I don't remember if it breaks down what prima and multi means, but if they don't, I will go into detail about that. So here's to show the difference between true labor pains and false labor pains. I'm gonna let y'all read that for just a second, see if y'all pick up anything there. So the biggest thing there is like Braxton Hicks. So bloody show is if you have a present of brown, it's more of a Braxton Hicks. True labor, the bloody shows is a pink or reddish or generally compromised by mucus. Those are kind of one of the things that kind of stand out. If you smell, if you see any type of blood or anything like that, you just need to make sure the color wise. Some women experience a premature rupture of the membrane in which the amniotic sac ruptures too early and the fetus is not developed or ready to be born. The patient may or may not go into labor. You will need to provide supportive care and transport to the hospital. Toward the end of the third semester, the head of the fetus normally descends into the woman's pelvis as the fetus positions for delivery. This movement down into the pelvis and the sensation that may accompany the descent is called lightening. The second stage of labor begins with the fetus begins to encounter the birth canal and ends with the delivery of the newborn or spontaneous birth. Make a decision about helping the woman to deliver at the scene or providing transport to the hospital. Your contractions can tell you those. Uterine contractions are usually closer together and last longer. The perineum will begin to bulge significantly at the top of the fetus's head, should begin to appear at the vaginal open, which is what we call crowning. The third stage of labor begins with the birth of the newborn and ends with the delivery of the placenta. During the stage of the placenta must completely separate from the uterine wall, and this can take up to 30 minutes. Preparing for delivery. Consider delivery at the scene when delivery is intimate. When they know that they're crowning, you see the child's head, you know that it's going to be shortly. Natural disaster, inclement weather, or other environmental factors make it impossible to reach the hospital. Stay on scene and prepare for that delivery. You need to bring all your stuff in and prepare to do a home, business, whatever type of delivery you may be at. To determine if the delivery is intimate, ask the patient some of the questions below. How long have you been pregnant? When are you due? Is this your first pregnancy? Are you having contractions? And how far apart are they? How long do they last? And have you had any spotting or bleeding? Has your water broken? Do you feel as though you need to have a bowel movement? And do you feel the need to push? If there's been any complications, were any of your previous deliveries by cesarean section? Have you had any problem in the previous pregnancies? Do you use drugs, drink alcohol, or take any over-the-counter medications? Do you know if there's any chance you will be having multiple deliveries? And does your physician expect any complications? If the patient says that she is about to deliver, says she has to move her bowels, or feels the need to push, you need to get ready to catch. Usually inspect the vagina to check for any type of crowning. Do not touch the vaginal area until you have determined that delivery is intimate. Get this done real quick. All right, once labor has begun, it cannot be slowed, stopped, paused, or rewound. Never attempt to hold the patient's leg together. That's not going to keep the baby from being delivered. Do not let her go to the bathroom because that baby will be delivered in the toilet. Instead, reassure her that the sensation of needing to move her bowels is normal, and that means she's about to deliver the child. If your decision is to deliver at the scene, remember you are the only assisting the woman in delivery. Your part is to help guide and support the baby as it is born. Your kit should always be equipped with an OB kit, and it's going to have some of the items you see there. You'll see a scalpel. You'll see I don't know if y'all can see this real well. Here's your scalpel. Here's your cord clamp. all these bags to hold the placenta and a few other things is just to help. Helping the delivery, some sanitary pads, a few things like that. Be familiar where these kits are on your truck, just as a FYI, CYA, so you don't look like a goofy going to try to find it and you don't know where it's at. The patient's clothing should be removed or pushed up to her waist, and pants and undergarments should be taken off. Preserve the patient's privacy as much as possible. Place the patient on a firm surface that is padded with blankets, folded sheets, towels, pillows, it don't matter. Elevate the hips about 2 inches with a pillow and or blankets. Support the patient's head, neck, and upper back with pillows and blankets. Have her keep her legs and hips flexed with her feet flat on the surface beneath her and her knees spread apart. Place, put on a protective face shield and gown. At this time allows, as time allows, to place towels or sheets on the floor around the delivery area to help soak up some of the bodily fluids and to protect the woman and the newborn. Open the OB kit carefully and so the contents remain sterile. Use the sterile sheet and drape from the OB kit to make a sterile delivery. Here is what it's going to look like. You can see as you prepare for a field delivery, you're using sterile sheets to drape over the legs and drape another sheet over the woman's abdomen to try to keep everything as sterile as possible, because when the child comes out, we're going to clear the airway and we're going to move it up to the mother's chest. That right there is showing that there's intimate delivery happening. Your partner should be at the patient's head to comfort, soothe, and reassure her during this delivery process. If the patient will allow, administer oxygen. If it is common for the patient to become nauseated during delivery and may vomit, constantly check the patient for crowning. Some patients may experience preeclampsia, labor, and birth. Position yourself so that you can see the perineal area at all times. The patient's contractions. Remind the patient to take quick, short breaths during each contraction, but do not strain. Between contractions, encourage the patient to rest and breathe deeply through her mouth. Deliver the head. Observe the head as it begins to exit the vagina so you can provide support as it emerges. Place your sterile gloved hand over the emerging bony parts of the head to control the delivery of the head. Continue to support the head as it rotates naturally. It will naturally rotate to where the head will come out, it'll dip down, one shoulder will come out as the other one protrudes to come out the same way. Be careful that you do not poke your fingers into the newborn's eyes or into the fontanelles. That is dangerous. We want to be very safe about that. If you potentially have a unruptured amniotic sac, usually the amniotic sac will rupture at the beginning of labor or during contractions. If it has not ruptured by the time the fetal head is crowning, it appears as fluid sac emerging from the vagina. The sac will suffocate the child if not removed. You may puncture the sac with a clamp or tear it by twisting it between your fingers. Make sure that the puncture site is away from the fetus's face and only perform this procedure as the head is crowning. Clear the newborn's mouth and nose. Use the bulb syringe if required by your protocols, and wipe the mouth and nose with the gauze. So, if you have to rupture the placenta, be prepared for a lot of water. Make sure that you have everything in place to cover everything up. The umbilical cord possibly stuck around the neck. As soon as the head is delivered, use one finger to feel whether the umbilical cord is wrapped around the neck, which is called a nuchal cord. Usually you can slip the cord gently over the head as it's delivered. If not, you must cut it at the point to keep the child from suffocating. The head is the largest part of the fetus. Once it is born, the body usually delivers easily. Support the head and upper body as the shoulders deliver. Never, ever, ever pull on the child from the birth canal. The newborn will be slippery and may be covered in a white, cheesy substance called the Vernix caseina, if I pronounced that correctly. Not sure if I did. I'm an OB specialist. Post-delivery. If the mother is able and willing, hand the newborn to her and place the newborn on her abdomen for skin-to-skin contact to begin immediately. Dry the newborn off and wrap him or her in a warm blanket or towel. Wrap the newborn in a clean blanket or towel to maintain warmth. Ensure that the top of the head is covered. Keep the neck of the newborn in a neutral position. Wipe the newborn's mouth with a sterile gauze pad as needed. Clamp and cut the umbilical cord after approximately 60 seconds and obtain a 1-minute Apgar score. The placenta delivers itself usually within a few minutes, although it may take as long as up to 30 minutes. You see on your screen right there, never pull on the end of the umbilical cord, because of what that's potentially doing is you're creating an unintentional tear of the skin on the inside as you're trying to pull that placenta out. I will tell you though, once you clamp it and cut it between the two clamps, never let go of the placenta towards the female side. The other side will be cut and delivered towards the fetus side. But remember, always hang on to that, because it can, not saying that it will, but it can also retract back into the female. And that's not what we want. Because then that is a surgical procedure that they have to go in and potentially remove that. We want to make sure that we're able to hang on to it. We're not pulling tension on it. We're just not letting it retract back up into the female. Here's some of the things that you're going to have to potentially do. After the delivery of the placenta and before transport, place a sterile pad or sanitary napkin over the vagina and straighten the woman's legs. You can now help to slow bleeding by gently massaging the woman's abdomen with a firm circular kneading motion with one hand cupped over the top of the fundus and the other over the pubic bone. Like wax on, wax off. We're trying to apply pressure to keep it from bleeding everywhere. Record the time of birth in your patient's care report. The following for emergency situations. More than 30 minutes elapsed and the placenta has not delivered. There is more than 500 milliliters of bleeding before the delivery of the placenta. There is significant bleeding after the delivery of the placenta. And if one or more of these events occur, transport the woman and the newborn to the hospital promptly. I've delivered the placenta in the back of the ambulance, so I didn't wait around. The first few times I was like, I don't want this baby in my hands. I'm scared. I didn't know what to do. So I transported the two, and we delivered the placenta on the way to the facility, or as we were arriving at the facility. I didn't wait around. When it comes time to do a neonatal resuscitation, the first minute of birth is often referred to as the golden minute. During the first minute of life, you're going to want to know this, y'all. During the first minute of life, perform the following initial steps to the newborn care. Airway positioning, suction as needed, drying, warming, and tactile stimulation. We want to make sure we dry them completely as much as we can. We are going to warm them, keep them warm, wrap them up, keep them covered, skin to skin contact. And tactile stimulation is like rubbing their feet. We want them to cry. I'm not trying to say poke them and aggravate them, but we want them to cry, and that is a tactile stimulation. Normally, the newborn begins, we talk about our CPR here. They start breathing with about 30 seconds after birth, and their heart rate will automatically be about 100 beats or more. Many newborns require some of the form of stimulation that will encourage them to breathe air and begin circulation blood through the lungs. This includes positioning the airway in a neutral or sniffing position. If y'all remember, sniffing position is kind of with their head up at a like a 45-degree angle. If necessary, then suction the mouth and the nose. Vigorously dry the head, body, and back. Rub the newborn's back and generally flick or slap the soles of her feet. That is tactile stimulation. If signs of good tone and adequate ventilation are not present after performing the initial steps for 30 seconds, then positive pressure ventilation with a mask may be necessary. Here we can talk about some resuscitation for the newborn who is not breathing. This should be from your CPR. You should basically remember how to do this. I hope nobody's had to use their CPR since the start of this class, but just know that in time it is probably coming for that to happen or take place. Observe the newborn for spontaneous respiration, skin color, and movement of the extremities. Evaluate the heart rate by palpating the pulse at the base of the umbilical cord or at the brachial artery, or listening to the newborn's chest through your stethoscope. If the heart rate is the most important measure to determine the need for further resuscitation. Chest compressions are required. Use 2 hands encircling technique for 2-person resuscitation. Perform bag valve mask ventilations during a pause and after every 3rd compression, using compression ventilation to a rate of 3-to-1. Hands-only CPR is not as effective as ventilation with CPR. Here's our picture right here to kind of go over the EC method. We can use our thumbs as a kind of a good push down, and the other provider is ventilating this baby. If you see meconium or in the amniotic fluid of the meconium staining and the newborn is not adequately breathing, consider quickly suctioning the newborn's mouth, then nose after delivery and before providing rescue ventilations, because we want to get that nastiness out. We want to clear them. We want to make sure that there's nothing in their way, and then we can ventilate them. We can give them their proper ventilations and to potentially do some resuscitation. All right, so here's your Apgar score. So this is important. This is very important. The Apgar score is the standard scoring system used to assess the status of the newborn. It assigns a number value 0, 1, or 2 to 5 different areas. You have appearance, pulse, grimace or irritability, activity or muscle tone, and respirations. Obviously, 0s are bad and 2s are good. You got there and let y'all read that some more before. I got that. You're able to write that down. Good. All right, the total of 5 numbers is the Apgar score. Calculate the Apgar score within 1 minute of birth and then after 5 minutes. Obviously, the highest possibility of Apgar score is 10. Here's a chart. Majority of these are in some of your field guides. Those are just in present, so you can look at that as a reminder. I don't expect any of y'all to remember this. I expect you to memorize it so you can go through National Registry. But I, to this day, since I don't deal a lot with pediatrics, I don't remember and recall how to do the Apgar score perfectively. It's a challenging skill that I know, but I don't 100% know it every single time. I always have to look. Steps for assessing a newborn. We are going to quickly calculate the Apgar score to establish a baseline of the newborn status. Stimulation should result in an immediate increase in respiration. If not, you must begin ventilations with a bag valve mask. If the newborn is breathing well, you should next check the pulse rate by feeling the brachial pulse or the pulsations at the base of the umbilical cord, or listening to the chest with the stethoscope. The pulse rate should be at least 100 breaths a minute. If it's not, begin ventilations with a bag valve mask. Reassess respirations and heart rate at least every 30 seconds. Assess the newborn's oxygenation via pulse oximetry, which is the best taken at the right risk, and observe for central cyanosis. You don't want them to turn colors. You need them to get a pinkish color. If present, administer blow-by oxygen by holding oxygen tubing at the high flow close to the newborn's face. Set oxygen flow rate for 5 liters a minute. So there you go. That's what our high flow is going to be for newborn, is 5 liters a minute. So request a second unit as possible if you determine that the newborn is in any sort of distress and requires resuscitation. If this in situations where assisted ventilation is required, you should use a newborn bag valve mask. Make sure you have a good mask to face seal. Use gentle pressure, making the chest rise with each ventilation. If the newborn does not begin breathing on its own or her own, or does not have any adequate heart rate, continue CPR and rapidly transport. Once CPR has been started, do not stop until the newborn responds or is pronounced dead by a physician. So in complicated deliveries, we're going to talk about a breech delivery here. All right, so the presentation is the position in which an infant is born or the body part is delivered first. Most infants are born head first, called a vertex presentation. Occasionally, the buttocks are delivered first, called a breech presentation. The fetus is at great risk for trauma for this type of delivery, and a prolapse cord are more common in breeched deliveries. Breech delivery does take longer, so you will often have time to transport the patient to the hospital. However, if the buttocks have already passed through the vagina, the delivery has begun. You need to call med control ASAP and be like, I need some help. But give them a very detailed status of what's going on, patient status, are they awake, alert, oriented, are they any type of distress, and they will give you further direction on what you need to do. Preparing for a breech delivery is the same as for a normal childbirth. Allow the buttocks and legs to deliver spontaneously, supporting them with your hand and prevent rapid explosion. Let the legs dangle on either side of your arm while you support the trunk and chest as they are delivered. The head is almost always face down and should be allowed to deliver spontaneously. You need to make a V with your gloved hand and position them at the vagina to keep the walls of the vagina from compressing on the fetus. Make sure, y'all understand, please, 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 that you make sure that you explain what's going on to the patient and potentially husband, wife, family member that is in the room with them. They need to understand why you're putting your hand there and what's going on. On rare occasions, the presentation part of the fetus is neither the head nor the buttocks, but a single arm, leg, or foot. This is called a limb presentation. It is shocking when you take a look and you see a hand or a foot. You're just like, what's this? I don't know what to do with this. So be prepared. Make sure you have your poker face on, but it will shock you. An infant with a limb presentation cannot be successfully delivered in the field. You must transport the patient to the hospital immediately. If a limb is protruding, cover it with a sterile towel. Never try to push it back in and never pull on it. Place the patient on her back with her head down and pelvis elevated. That's a tongue twister. Prolapse of the umbilical cord, where the umbilical cord comes out of the vagina before the fetus, must be treated in the hospital. Do not attempt to push the cord back into the vagina. Your job is to try to keep the fetus's head from compressing on the cord because that's its lifeline. Carefully insert your sterile gloved hand into the vagina and gently push the fetus's head away from the umbilical cord. Place the woman supine with her foot on the stretcher raised up about 6 to 12 inches higher than her head, with her hips elevated on a pillow or folded sheet. Alternatively, the woman may be placed on the knee to chest position. Wrap a sterile towel moistened with saline around the exposed cord and give the patient high flow oxygen and transport rapidly. Now, you may need high flow oxygen too because you're like, oh my God, I got to do what? I got to put my hand where? Just know this is the process, but you have to keep that cord from being compressed. Otherwise, the child will die. If you happen to notice spinal bifida, the developmental defect in which the portion of the spinal cord or meninges may protrude outside of the vertebrae and possibly outside of the body. Cover the open area of the spinal cord with a sterile, moist dressing immediately after childbirth to help prevent any type of fatal infections. Maintenance of the newborn's body temperature is vital when applying moist, sterile dressings because the moisture can lower the newborn's body temperature. Most of these that have had prenatal care are made to stay in the facility at any time. They get them close to delivery and they bring them in and then they induce them their own. Now, if you come across one that has not had any prenatal care, this is when you may see spinal bifida. Twins may occur about once in every 30 births. Twins are usually smaller than the single fetuses, and the delivery is typically not difficult for the twins. At about 10 minutes of birth, the first birth contractions will begin and the birth process will repeat itself. The procedure for delivering twins is exactly the same for a single fetus. However, you will need some supplies from an additional OB kit. Clamp the cord and cut it for the first newborn as soon as it has been delivered, and the second newborn is delivered also. Record the time of the birth of each twin separately. Twins may be so small that they look premature. Premature births are any newborn who is delivered before 8 months or 36 weeks and weighs less than 5 pounds. A friend of ours just had their baby a while back. Today was actually their birth date. When she was born, she was 1 pound and 11 ounces. She is now finally home after being delivered, and I think she was in the hospital 3 months, maybe. Let's see, February, March. Almost 3 months. Right at 3 months. So she's doing good now. She's 5 and some pounds. Premature birth is smaller and thinner than a full-term newborn, and the head is proportionally larger and is compared to the rest of the body. The vernix caseinaria will be absent or minimal on the premature newborn, and there will be less body hair also. They both look unhappy. Premature newborns require special care to survive. They often require resuscitation efforts, which should be performed unless it is a physically impossible. With such care, premature newborns are so small that 1 pound have survived and developed normal. Postterm pregnancy. Postterm pregnancy refers to pregnancies lasting longer than 41 weeks. Postterm fetuses can be larger than a typical 40-week fetus, sometimes weighing 10 pounds or more. The larger fetuses can lead to problems in a woman and fetus, a more difficult labor and delivery. So again, most of these are brought into the facility sooner and delivered inside the ER. Now, I've had one delivered, she is a friend of mine. I delivered her third child, and it was a 10-pound baby. She was actually on the way to the hospital to prep for delivery and all that. So I actually got to deliver a friend of mine's baby. Increased chance of injury to the fetus. It is increased likelihood of cesarean section being required on a postterm. Women are more at risk for perineal tears and infection. That is the tear between the vagina and the rectum. Postterm newborns have increased risk of meconium aspiration, infection, and being stillborns. Newborns may have been able to develop normally because of the restricted size of the uterus. Be prepared to resuscitate the newborn as respiratory and neurologic functions may have been affected. We talk about fetal demus is the onset of labor and premature, but labor will otherwise progress normally in most cases. If an intrauterine infection has caused the demus, you may note an extremely foul odor. The delivery fetus may have skin blisters, skin sloughing, and dark discoloration. The head will be soft and perhaps grossly deformed. Do not attempt to resuscitate any obvious dead neonate. Postpartum complications, any type of bleeding that it exceeds 1,000 milliliters is considered to be excessive. If bleeding continues after delivery of the placenta, you should continue to massage the uterus. You treat any signs or symptoms of shock, we know you elevate their feet, provide high flow O2 for them. Excessive bleeding after birth is usually caused by the muscles of the uterus not fully contracting and is potentially life-threatening. Cover the vagina with a sterile pad, changing the pad as often as possible. Administer oxygen if necessary. Monitor vital signs like we should already. Transport rapidly and immediately to a hospital. Never hold the woman's legs together or pack the vagina with gauze in an attempt to control bleeding. Never pack the vagina with gauze, pads, and an attempt to control the bleeding. So I don't want you to pack any of the vagina with anything. You can cover it, but remember, we need to make sure we start doing the massaging. Postpartum patients are also at an increased risk of venous embolism, most commonly a pulmonary embolism. A pulmonary embolism results from a clot that travels through the bloodstream and becomes lodged in the pulmonary circulation, blocking blood flow to the lungs and is potentially life-threatening. The obstruction will block blood flow to the lungs and is potentially life-threatening. If you deliver a newborn in the field and the woman begins to report sudden difficulty breathing or shortness of breath, consider pulmonary embolism as a possibility. Also suspect a pulmonary embolism in the patient of a childbearing age with respiratory complaints who have recently delivered, especially with a sudden onset of difficulty breathing or altered mental status. Ladies and gentlemen, this is it for tonight. I did open your test. I think it opens at 9 tonight. I opened it a little bit earlier because I know that your mod test opens also tonight. If y'all will give me a few minutes before the class is completely over, I will tell y'all, but matter of fact, I will go in here and change this right now, and I will open chapter 34's test up at 8 o'clock. Wow, I don't know what happened here. Hang on 2 seconds, y'all. Does anybody have any questions, concerns, problems? Y'all want to talk about anything? We want to go back over anything in this chapter particularly. Tammy, how big was your baby? You said it was so small. Well, it was 10 days. So you were what, 42 weeks? No, that was definitely not right. I just did way bad math. 6 pounds, 6 ounces. Wow, that was a little bitty baby. Whew. All right, so I am adjusting your test. Your test for tonight will open at 8 o'clock. Your other test will open up at the same time. If the test will allow me to do this, I will get it. This will open up at 8 o'clock. All right, so chapter 34 will open up at 8 o'clock tonight. You'll have 3 days to complete chapter 34. You will need, you will be given 4 days to complete your mod exam. Your mod will open at 10 o'clock tonight and will close at 11:59 on Monday night. Nobody has any questions, concerns, or problems? Here is your class code for tonight. Let me type that in the chat. Shift at. There you go. Other than that, y'all have a great weekend. Be safe, stay strong, and we'll see y'all Tuesday. So 32 and 34. 32 has been open, and I think it's closed. I'll have to look real quick. Let's see here. 32 closes on the 24th. So this is allow me to take the test. So let me see here. Don't go nowhere yet. Let me look. Let me look at one more thing before I tell you any answer.